The following are some of the core anatomical concepts that I certainly wish I knew a lot sooner than what I did. If we understand these concepts, then that will facilitate a more comprehensive assessment of the shoulder, one that can be performed efficiently, but more importantly, accurately. Now, the first concept to understand is that of the enthesis or footprint. Now, an enthesis is where a ligament, tendon, or joint capsule attaches to the bone. And this is the first thing that I'm looking at when I assess the rotator cuff. Now, in a fibrocartilage enthesis, there are 4 zones or parts. We have the collagen of the tendon, the unossified fibrocartilage, which is this hypoechoic area that's often misinterpreted as a tear. Underneath that, we have the calcified fibrocartilage, and then deep to that is the cortical bone. And we need to be able to identify the enthesis of supraspinatus, subscapularis, and infraspinatus, because the majority of rotator cuff tears are enthesis-based tears. And if we have an unhealthy enthesis, we'll have an unhealthy tendon. Take this case for example. As we scan through this supraspinatus, the first and most striking feature is the irregularity of the enthesis. This enthesis irregularity is often associated with a tendon tear, which indeed we do see. And in another case, again, we see irregularity at this point with an associated partial thickness tear in long and in transverse or short axis. This is often described as cortical irregularity, but technically it's not. I reserve the term cortical irregularity for cases in which we have an incongruent cortex, such as the case of a fracture of the radial tuberosity or a Hill-Sachs depression fracture. As I said before, if we have an unhealthy enthesis, we'll have an unhealthy tendon, and we can use a low-flow Doppler or SMI to prove this. Vessels should not cross the enthesis, and if we do see vessels that cross the enthesis, these are pathological. This image here is not cortical irregularity, nor is it enthesis irregularity. This is a normal finding. It is a synovial herniation pit, which we commonly see deep to subscap, supra, and infraspinatus, and the key distinction here is in its location. These will occur at the junction between the enthesis and the hyaline cartilage. So on an x-ray, this is the enthesis of supra. The hyaline cartilage is located here, and the junction between the cartilage and the enthesis is where we will see these synovial herniation pits. Another application of our enthesis knowledge comes in handy in this case. Here we can see a calcified linear focus, and this is not hydroxyapatite deposition disease, but this is part of the calcified fibrocartilage that has evolved. We have a high-grade tear of supraspinatus, and sometimes this is often referred to as an enthesis lift-off injury. The next concept to grasp is that of the rotator cable and rotator crescent. Now, when it comes to the cable, I just think of this as an extension of the coracohumeral ligament, which we touched on in our rotator interval section. As the coracohumeral ligament dives down deep to form the floor of supraspinatus and infraspinatus, it becomes the rotator cable. If we look at this in our longitudinal view, then the lateralmost ends of supraspinatus and infraspinatus form the rotator crescent. And this is just another way to visualize the rotator cable and the rotator crescent. Thanks for listening, guys. Like and subscribe for more content.